Hello everyone and welcome to our module on disorders of sexual development. I'll begin by discussing sex chromosome disorders. These are disorders that can lead to abnormal sexual development, but they're actually not the major focus of this video today, but I want to briefly review these to make an important distinction. So in sex chromosome disorders, there is aneuploidy, meaning an abnormal number of sex chromosomes. So for example, in Turner syndrome, girls born with this condition are usually 45X. They're missing one X chromosome. In Klinefelter syndrome, boys are born with an extra X chromosome usually, so they are 47XXY. And I talk about both of these disorders in the genetics section. They can both lead to abnormal sexual development. There's also a third sex chromosome disorder you should be familiar with for step 1 of your boards. That's called double Y males. These are males with an extra Y chromosome. They're usually normal appearing and have normal fertility, but they are tall, sometimes with severe acne. And the major issue here is that they often develop learning disabilities and autism. But in all of these conditions, the problem is that you have too many or too few sex chromosome disorders. And these are different from what we're going to talk about in the rest of this video, which are disorders of sexual development. In disorders of sexual development, there is a congenital discrepancy between the chromosomal sex, which is either XX or XY, and the gonads, the testes and ovaries, and the external genitalia. So individuals with any of the disorders we're going to talk about in this video have a normal number of sex chromosomes. They're either XX or XY. But for one reason or another, their gonads and their genitalia do not develop normally. First, let's briefly review normal sexual development, which I discuss in more detail in the video on genital embryology. Always remember that the default genital development in humans is female. In order for male development to occur, special factors have to be present. These include testosterone, dihydrotestosterone, and Müllerian inhibitory factor. So disorders of sexual development occur when there are presence of some of these male factors in a female with two X chromosomes, or there is an absence of one of these factors in a male with an X and a Y chromosome. And so as you can imagine, when a baby is born and there is a suggestion of a disorder of sexual development, a key test is a karyotype. What you want to know is, what is that baby's chromosomal sex? Is it XX or XY? Once you know that, you can look for the presence or absence of other factors that may have led to abnormal sexual development. And here's a slide showing all the factors required for male genital development. First of all, there needs to be a Y chromosome with the SRY gene. That gene codes for testis determining factor, which turns the gonads into testes. The testes will have Sertoli cells, which secrete Müllerian inhibitory hormone, and that causes the Müllerian system, the female system, to degenerate. The testes also have Leydig cells, which make testosterone. Testosterone drives the mesonephric ducts in the embryo to form the internal genitalia, all these structures shown on the slide. And testosterone is also converted into dihydrotestosterone, and that drives formation of the external genitalia. So as you can imagine, there are a number of points in this process where something can go wrong, and this can cause an individual that is XY to end up not looking male because one of these factors is missing. Most disorders of sexual development present in one of two ways. The first way is ambiguous genitalia. This is an example of ambiguous genitalia shown on the screen. You can see that it's hard to tell from the external genitalia whether this is a male or a female. This is a common presentation of disorders of sexual development. This can happen anytime an XX female is exposed to excessive androgens or an XY male develops with insufficient androgen activity. The other way these disorders sometimes present is with normal female external genitalia. In other words, a baby is born with normal female external genitalia and appears to be a girl, but it's actually an XY male who lacks androgen activity. This will only be discovered at puberty when the individual fails to menstruate and develops secondary female characteristics. A workup then will discover that it's actually an XY male individual missing androgen activity. The first disorder of sexual development we'll discuss is the easiest to understand. It's also very rare. It's called ovotesticular disorder of sexual development. This happens when an individual is born with ovaries and testes present. Often there are separate ovaries and testes inside the pelvis. Sometimes there are what's called ovotestes, which is where both tissue types are found in one structure. In 80% of cases, the chromosomal sex is female, meaning it's an XX individual, and the only way this is diagnosed is by a gonadal biopsy showing presence of both ovarian and testicular tissue. There's a range of male and female genital development in this disorder. It depends on how much ovarian and testicular tissue is present. The vagina can be abnormal. The uterus may be underdeveloped, which is called hypoplastic uterus. Often the testicles don't descend. This is called cryptorchidism. There's often an abnormal penis. At puberty, because there's some ovarian tissue present, breasts may develop and menstruation may occur, and usually these individuals are infertile. So an ovotesticular disorder is very rare, and it's really different from all the other disorders of sexual development. For the rest of this video, I'm going to talk about other disorders of sexual development, and those are classified as either XX disorders of sexual development or XY. In the XX forms, the individual is genetically female. She has 2 X chromosomes, but she has abnormal sexual development. And this happens anytime there is the presence of male factors in an XX chromosomal female. XY disorders of sexual development occur in a genetic male with an X and a Y chromosome who experiences some absence of male factors and therefore doesn't develop in the normal male fashion. Let's talk about the XX disorders first. In these disorders, the individual is chromosomally female and has 2 X chromosomes, so ovaries are usually present, but the external genitalia are ambiguous. And the reason the external genitalia are ambiguous is because the female baby has been exposed to androgens in utero. Remember, androgens drive formation of external male genitalia, so when this occurs in a chromosomal female, the external genitalia come out ambiguous. These disorders have a relatively narrow list of causes, and the 2 classic causes that you should know are congenital adrenal hyperplasia and gestational hyperandrogenism. In both of these problems, there is excess androgen production in utero that causes the sexual development to be abnormal, and the fetus is most vulnerable at 7 to 12 weeks of gestation because this is the time period when the genitals are forming. In the endocrinology section, I talk about congenital adrenal hyperplasias, and the classic congenital adrenal hyperplasia disorder is a 21-alpha hydroxylase enzyme deficiency. When children are born deficient in this enzyme, they cannot synthesize cortisol. As a result, the pituitary increases its release of ACTH, and this causes the adrenal gland to become hyperplastic. That's why it's called adrenal hyperplasia. In addition to the inability to make cortisol, the adrenal gland in individuals who are deficient in 21-alpha hydroxylase also cannot make aldosterone normally. These babies can, however, make normal levels of androgen, so because cholesterol cannot be shunted to cortisol and aldosterone, it all gets shunted towards androgen production, and excess androgens are produced. And in a female baby with 2 X chromosomes, that will lead to a disorder of sexual development because the high levels of androgens coming from the adrenal gland should not normally be present in a female child. 21-alpha hydroxylase deficiency is the classic cause of congenital adrenal hyperplasia. It's responsible for 90% of cases. Depending on the severity of the enzyme deficit, there can be low cortisol symptoms, which often manifest as hypoglycemia. There can also be symptoms from low mineralocorticoid activity, meaning low aldosterone levels. This can lead to salt loss, which causes the child to be volume depleted. It can also lead to hyperkalemia. And then the androgen symptoms depend on the chromosomal sex of the child. So if it's a girl, that girl will have ambiguous genitalia because of all the excess androgens. If it's a boy, that boy will develop precocious puberty. The excess androgens aren't going to cause the boy to develop like a female. It will still look like a boy, but puberty will occur at a much earlier age because of all the androgens coming from the adrenal gland. Another cause of XX disorders of sexual development is gestational hyperandrogenism. In this problem, there is a maternal source of androgens when the mother is pregnant. What this means is that the baby may develop as a male if it's an XX female baby, but in addition, the mother will develop signs and symptoms of androgen excess. So typically during pregnancy, the mother develops hirsutism and virilization. This means she may have facial hair growth, her voice may deepen, and she may develop acne. This is all from high androgen levels during pregnancy. In addition, if she happens to have a female fetus in her belly, this will lead to virilization of the female fetus. So what can cause this during pregnancy? Well, there are rare gestational masses. The most common is an ovarian mass called a luteoma. It can secrete testosterone and dihydrotestosterone to cause this problem. In addition, sometimes for various reasons, mothers need to take progestins or androgens when they are pregnant. For example, some women are given progestins for threatened abortion, and progestins have some androgen activity, and that can cause this problem as well. Another way that high levels of androgens can develop during pregnancy is if the placenta lacks the enzyme aromatase. This is rare, but sometimes the placenta does not have activity of this enzyme. Normally, the placenta synthesizes estradiol and estrogen from testosterone and androgen. This requires the enzyme aromatase, so if aromatase is deficient, then androgens will build up in excess. Shown at the bottom is the pathway by which the placenta synthesizes estradiol and estrogen. So androstenedione is converted to testosterone, and then aromatase converts testosterone into estradiol. So if the placenta lacks aromatase, then the levels of testosterone and androstenedione will build up. These can cross the placenta and enter the maternal circulation. This means that if the baby is XX, the baby will become virilized and develop male features such as ambiguous genitalia. But in addition, the mother will develop virilization like we talked about before, She may develop facial hair and acne, and her voice may change. Now let's talk about the XY disorders of sexual development. In these disorders, the individual is chromosomally male because they have an X and a Y chromosome, so testes are usually present, although not always. We'll talk about that in a minute. The external genitalia may be ambiguous or may be female. Remember, when there's a disruption in any of those many factors necessary for male development, the baby may be born appearing to be female. And in general, these disorders happen anytime a male baby, meaning a baby with an X and Y chromosome, is underexposed to androgens in utero. There are many potential causes of XY disorders, many more than the XX disorders. These disorders are more complicated because male development is so much more complicated. But the three causes that you should definitely know for step one are gonadal dysgenesis, a 5-alpha reductase deficiency, and androgen insensitivity. In addition, there are some other causes. There are rare forms of congenital adrenal hyperplasia, where male babies cannot make androgens, and there are rare defects in testosterone synthesis, but we'll focus on these three causes in the next few slides. Swyer syndrome is also called XY gonadal dysgenesis. This is when an XY chromosomal male is born, but the gonads do not develop. That's why it's called dysgenesis. This will be a female baby with XY chromosomes and no ovaries. Remember, the gonads do not develop, so there are no testes or ovaries, but chromosomally, the individual is a male with an X and a Y chromosome. Instead of gonads, what these babies have are called streak gonads. The gonadal tissue is mostly fibrous tissue, and there is a risk of malignancy developing in the streak gonads, so they are often removed surgically. Babies with Swyer syndrome have female external genitalia. In addition, the Müllerian ducts remain intact and develop into the uterus, cervix, and upper vagina. This is because there are no Sertoli cells in the testes present to release Müllerian inhibitory hormone. So even though the baby has an X and a Y chromosome and is chromosomally male, the external genitalia are female and the internal genitalia of a female are also present. At puberty, however, there will be no menstruation and no development of puberty. That's because there are no functioning ovaries to produce an increase in estrogen. And for this reason, estrogen supplements are often given, and these children are raised as females even though they have an X and a Y chromosome. Moving on, let's talk about a 5-alpha reductase deficiency. 5-alpha reductase deficiency is an autosomal recessive disorder, so affected children must have two parents who are carriers of the abnormal gene, and this will result in a child that is 46XY chromosomally male who is able to make testosterone but not dihydrotestosterone. Recall that 5-alpha reductase makes dihydrotestosterone from testosterone. And if we go back to our map of male development, dihydrotestosterone is required for external genitalia development in the male. So in a baby that cannot make dihydrotestosterone, the external genitalia will not develop as male and will appear to be female. However, the internal genitalia, which only require testosterone, will be male, and the testes will also form, which means Sertoli cells will release Müllerian inhibitory hormone, and that will lead to degeneration of the Müllerian structures, so there will be no uterus, cervix, or upper vagina present. So I've summarized these points on this slide. A 5-alpha reductase deficiency occurs in a chromosomal male with an X and a Y chromosome. That male will have normal internal male genitalia, so there will be an epididymis, a vas deferens, and presence of seminal vesicles. These will all connect to a blind-ending vagina. The external genitalia are predominantly female, and especially in a board question, there will be an absence of external male genitalia. In actual practice, there's a range of female genitalia seen. Sometimes the genitalia appear ambiguous. And then at puberty, this is interesting, there's usually masculinization. This is because at puberty, the testes begin producing more testosterone. This leads to muscle growth and development of male features, and some of that testosterone, it turns out, can get converted to DHT at the time of puberty, and this can lead to more masculinization. So the typical case is an XY chromosomal male with ambiguous genitalia, or it may be a female child that develops masculinization at puberty. If you do imaging of the abdomen and pelvis, there will be bilateral undescended testes. Importantly, the testosterone levels are entirely normal because the testes can make testosterone normally. Also on imaging, you can find a vas deferens and a seminal vesicle and all the internal male structures, but you won't see any internal female structures, so there will be absence of a uterus, and the vagina ends in a blind pouch with no cervix present, and externally there is missing or abnormal male external genitalia. Next, let's talk about the complete androgen insensitivity syndrome, which is a mutation of the androgen receptor that occurs in chromosomal males with an X and a Y chromosome, so that in this disorder, these male children, even though they have an X and a Y chromosome, cannot respond to androgens. If we go back to this slide, the important androgens for male development are testosterone and dihydrotestosterone. So if the androgen receptor doesn't work, then testosterone cannot exert its effects on the mesonephric duct. so the internal male genitalia will not develop. In addition, dihydrotestosterone cannot exert its effects, so the external genitalia of the male will not develop, and the baby will appear to be female. Remember, female is the default development. The testes are, however, present, and there are Sertoli cells that release Müllerian inhibitory hormone, so the internal Müllerian female structures will degenerate. What this means is that you will have a chromosomal male with an X and a Y chromosome. The external genitalia will be female, and internally there will be no structures whatsoever because the male internal genitalia did not develop and the internal female genitalia degenerated because of MIH coming from the Sertoli cells. I've summarized these points on this slide. The testes form in utero, so the SRY gene is present and there are no ovaries. There will be no internal or external male genital development because there is no cellular response to androgens, including testosterone and dihydrotestosterone. Now, because the testes are present, Sertoli cells will form and they will release Müllerian inhibitory hormone. This will lead to degeneration of the Müllerian structures, and thus there will be no internal female structures either. So there won't be internal male structures, and there will also be absence of a uterus and fallopian tubes, the internal female structures as well. So a baby with complete androgen insensitivity syndrome will be a chromosomal XY male with a female appearance. If you do imaging, you will find abdominal testes. There will be amenorrhea at puberty because there is no uterus. In addition, there are no ovaries to release estrogen. At puberty, there is some breast development. This is because the testes start making more testosterone. And even though this child did not respond to testosterone, it can respond to estrogen. And some of that testosterone will be converted to estrogen. This means that the breasts will get larger at puberty, but there's no armpit or pubic hair that develops because this all depends on androgens. This slide summarizes the three major causes of XY disorders of sexual development. Remember, in all of these disorders, the child is chromosomally male with an X and a Y chromosome, but has features of a female. In Swyer syndrome, the gonads do not develop, so internally the child is female and externally the child is female, and at puberty nothing happens because there are no ovaries or testes. In a 5-alpha reductase deficiency, the child has abdominal testes, internally the child is male, externally it appears female, and at puberty there is masculinization. And finally, in androgen insensitivity syndrome, the testes are found in the abdomen. Internally, there are no structures whatsoever. Externally, the child appears to be female, and at puberty there is no menses, but you can see breast development. This slide shows a concept map to help you approach board questions on disorders of sexual development. So if you're faced with a question involving a baby with ambiguous genitalia or a child who is not progressing normally through puberty, one of the first things you want to know is the chromosomal sex. If they tell you that it is a chromosomal girl, meaning 2 X chromosomes, then the number of causes is relatively narrow. There's some reason for excess androgens present. This could be congenital adrenal hyperplasia, or it could be maternal androgens, or some source of androgens coming from the placenta, like we talked about in this video. If they tell you that the child is XY, meaning a male, then it's a more complicated situation because there are many more things that can go wrong in male development. But one of the first things you want to know is whether there is presence or absence of Müllerian structures, meaning the uterus. So if they tell you that the uterus is present, then this means that it is most likely a case of gonadal dysgenesis. In gonadal dysgenesis, the gonads don't form and there's no MIH from Sertoli cells, so the uterus will be present even though it's an XY male. If they tell you that the uterus and other Müllerian structures are absent, then you need to look for some reason that there is a lack of androgen effects. This could be androgen insensitivity syndrome, it could be a 5-alpha reductase deficiency, or it could be some of the rarer forms of congenital adrenal hyperplasia. Next, let's talk about Kallmann syndrome, which can also lead to abnormal sexual development, but doesn't really fit into any of the categories we've talked about up until this point. Kallmann syndrome involves hypogonadotropic hypogonadism plus anosmia, which means loss of the sense of smell. This is caused by a deficiency of GnRH from the hypothalamus. That leads to decreased production by the pituitary gland of LH and FSH. These are the gonadotropes, and that's why this is called hypogonadotropic hypogonadism. This syndrome is caused by a mutation in a gene called CAL1. That's not really important for you to remember, but what you do want to remember is that this is a problem with the hypothalamus. It's believed to be caused by impaired migration of GnRH neurons to the hypothalamus. As a result, there are low levels of GnRH, and that leads to low levels of LH and FSH. To understand the clinical features of Kallmann syndrome, you need to appreciate that this is a form of hypogonadism. That means that the ovaries or the testes are underactive in production of androgens or estrogens. That means that the clinical features are going to depend on whether the baby is a boy or a girl. Now, this is primarily a disease of males. It occurs in males with a 5-to-1 ratio, so in a board question, this is most likely going to be a male baby. Newborn females will appear entirely normal. Even though their ovaries are underactive, that doesn't affect the genital development very much because remember, the default genital development is female, and female genital development doesn't require high levels of estrogens. Newborn males may have problems at birth. It depends on the severity of the syndrome. If they have very low levels of testosterone coming from their testes, then they may have a small penis. This is called micropenis, or they sometimes have cryptorchidism where the testes don't descend into the scrotum. Often, however, this isn't discovered until puberty. So what happens at puberty if the gonads don't work? Well, in a female, there will be little or no breast development and no axillary hair, and there will be primary amenorrhea. And in a board question, they're going to describe these features, and then they're going to tell you something about the hypothalamus being abnormal, or they may mention a decreased sense of smell. That is a description of Kallmann syndrome. What they're going to want you to recognize is that the problem is not in the gonads themselves. The problem is higher up in the system involving the hypothalamus. In males, the testes will be underactive at puberty, so there'll be no facial or body hair, no increase in muscle mass as you would expect from testosterone, and failure of the voice to deepen. And once again, this is because the testes, the gonads in the male, are underactive due to a problem in the hypothalamus. This slide summarizes some of the diagnostic tests that are useful when evaluating a child with abnormal sexual development. As I told you before, the karyotype is a key test. You need to know whether the child is XX or XY. Abdominal imaging can also be helpful. This can identify the presence of abdominal testes, especially in a child that appears to be female. It can also identify the uterus, which is an important Müllerian structure. The level of 17-hydroxyprogesterone is often measured. The reason for this is that this intermediate in steroid synthesis is elevated in congenital adrenal hyperplasia from 21-hydroxylase deficiency. And remember, this is the most common form of congenital adrenal hyperplasia. So by measuring this level, it's basically a screening test for the most common type of CAH. And then finally, you can also measure the levels of testosterone and dihydrotestosterone. In complete androgen insensitivity syndrome, both levels will be elevated. However, the level of dihydrotestosterone will be low in a child with a 5-alpha reductase deficiency. I'll finish with this slide on luteinizing hormone. Luteinizing hormone is a gonadotrope secreted by the pituitary, and in the male, there is negative feedback on the pituitary by testosterone. So LH levels should be low when testosterone is high, and they should be high when testosterone levels are low. And on your boards, they love to ask you these up-down arrow type questions to see if you can predict the level of luteinizing hormone in a particular male disorder. So let's go through that now by reviewing this table. So if the gonads in the male fail for any reason, there will be low testosterone levels because the gonads aren't working, and the pituitary will respond by releasing lots of LH, so the LH level will go up. If there's a tumor in the male producing testosterone, then the testosterone level will be high, but it's not coming from the gonads, it's coming from the tumor. The pituitary will respond by decreasing the level of LH. If a male child is exposed to exogenous testosterone, then once again the testosterone level will be high and the LH level will be low. If the pituitary gland fails for any reason, then the testosterone level will get low, and the reason it will be low is because LH is not being released from the pituitary gland to drive the testes. And then finally, in complete androgen insensitivity syndrome, the testosterone level is very high, but the LH level is also very high. Why is the LH level high? That's because the effects of testosterone cannot be felt by the pituitary gland because the androgen receptor is abnormal. So the pituitary gland thinks there is no testosterone and it releases lots of luteinizing hormone. And that concludes our video on disorders of sexual development.